Bowel incontinence, also called fecal incontinence, may occur as a result of injury to rectal, anal, or nerve tissue from trauma, childbirth, radiation, or surgery, and other structures involved in normal defecation or the result of diseases that alter the normal function of defecation. Infection with resultant diarrhea or neurological disease, such as stroke, multiple sclerosis, and diabetes mellitus can also result in bowel incontinence. In older patients, dementia can contribute to bowel incontinence when the individual cannot respond to normal physiological cues for defecation. Normal aging causes changes in the intestinal musculature that may contribute to bowel incontinence. The bowel incontinence can be defined as the change in normal bowel habits, characterized by involuntary passage of stool. The related factors of bowel incontinence may include the following: related to rectal sphincter abnormality secondary to anal or rectal surgery, obstetric injuries, anal or rectal injury, peripheral neuropathy. Related to overdistension of rectum secondary to chronic constipation, general decline in muscle tone, abnormally high abdominal or intestinal pressure. Related to loss of rectal sphincter control secondary to progressive neuromuscular disorder, spinal cord compression, cerebral vascular accident, spinal cord injury at the level of T11 or S2, S3, multiple sclerosis, myasthenia gravis, dementia, lower motor nerve trauma. Related to impaired reservoir capacity secondary to inflammatory bowel disease, chronic rectal ischemia. Related to impaired reservoir capacity secondary to colectomy, radiation proctitis, colorectal lesions. Related to inability to recognize, interpret, or respond to rectal cues secondary to depression, impaired cognition, stress. Musculoskeletal problems, pelvic floor relaxation, infection, fecal impaction, medications, hyperosmolar food or fluid intake, immobility. Toileting self-care deficit, environmental factors. Dietary habits, laxative abuse. The subjective data for bowel incontinence include: recognizes rectal fullness but reports inability to expel formed stool, urgency, inability to delay defecation. Urge incontinence. Self-report of inability to feel rectal fullness, passive incontinence. Fecal seepage. The objective data for bowel incontinence include: constant dribbling of soft stool, fecal staining of clothing and bedding, fecal odor, red perianal skin, inability to recognize or inattention to urge to defecate. The expected outcome from a patient with bowel incontinence include the following: patient is continent of stool or reports decreased episodes of bowel incontinence. Client will verbalize understanding of causative or controlling factors. Client will identify individually appropriate interventions. Client will participate in therapeutic regimen to control incontinence. Client will establish and maintain as regular a pattern of bowel functioning as possible.